So we're going to be discussing shoulder. You've had a lot of MSK classes in detail, right? So this one's the most basic of them all, predominantly targeted for the first years and people who are new to MSK as such. So I'm going to give you a bird's eye view of what is the anatomy, what should be your approach for reading MRI of the shoulder. And mainly when we talk about pathologies, there are two headings, right? One are the rotator cuff injuries and one are the labral injuries, which are because of recurrent dislocation. That is where MRI really comes in to look at what is the cause of recurrent shoulder dislocation. I'm sure you know that shoulder is the most common joint to dislocate in the body, and the reason is the ratio of the glenoid to the humeral head. The glenoid is way smaller than the humeral head. So that is the reason why it is the most common shoulder is the most common joint to dislocate. So those are the main indications for doing an MRI, mainly to evaluate the rotator cuff or the labrum. Okay, so that's what our focus has to be. So I'm going to give you a very, very systematic approach of joint, right? So yeah, ultrasound also will delve into, but right now let's focus on what we are doing. Okay, so that is very important कि जो पढ़ा है उसको अच्छे से करो. We are always full of requests, but जो हो रहा है उसको अच्छे से करो, right? You can't make mistakes in that. I'll also be covering up knee this month. Those I feel are the two most important joints, and the smaller joints, have already been covered by the experts. So let's start with shoulder, okay? And then we'll see a case. Sound is low, is it? I don't know. It's the same for me. I can pull the mic a bit closer. अपना device का थोड़ा no, not talking about ultrasound today, only MRI, okay? Not talking about ultrasound. Ultrasound, it's very difficult to, teach as a presentation. I don't know how much it'll benefit. Ultrasound, MSK ultrasound, the more you do, the more you'll become confident. So you have to be very thorough with the anatomy. And then once you practice, that's how you will get the hang of it. So I just feel very strongly about ultrasound in general that you can't teach it. The more you do, the more you will learn. And if you see my layout for the first time in conceptual radiology is changed. So I've gone with a black background because somebody had told me that for MSK it works better if you see it with a black background. I don't know. So I thought I'll give it a try because this is the first time I'm teaching you joints. So I thought I'll try it out so you can tell us. So starting with the examination protocol. So when we talk about MRI shoulder, first of all, what is the patient position? So this is how the patient should be placed, usually supine, and we use the surface coil, which is a shoulder joint coil. The most important thing is either keep the hand neutral or keep it externally rotated, right? You can see in this patient, it's externally rotated, but never internal rotation, because otherwise it messes up the appearance of subscapularis, okay? So that is the important part here, that the patient position, I'll talk about ABER in a bit, but the patient position should be supine with external rotation of the hand. So that is what is the patient position. Essentially, we take 5 sequences. It differs from institute to institute, but majority of these 5 sequences, out of which the first is an axial sequence. Why the first one is an axial sequence is because then we have to plan our coronal and sagittal obliquely. So the plane is that of supraspinatus. Okay, so the sagittal and the coronal images are planned along the supraspinatus. So you can see on the axial that this is the muscle belly of the supraspinatus muscle, and that's where you draw a line, and that's how you're gonna plan your coronal. This is your coronal oblique, and this is your sagittal oblique. Okay, so that is how the scan is planned. In axial, 2 sequences are usually acquired. PD is the workhorse, right? So proton density MR images are your workhorse for shoulder joint. We do take a gradient in axial because it helps you see the labrum very well, okay? So that is something that we definitely do. A gradient is acquired. Here I'm showing you coronal, but usually in an axial image, because that shows you the articular cartilage and the labrum the best, okay? So axial T1 gradient PD, coronal PD, and 1 coronal stir is also taken, and this is usually the first sequence we evaluate, because first off you will know कि कहाँ पे edema आ रहा है, कहाँ पे hyperintensity आ रहा है. So this is usually PD, fat sat, or a stir sequence is usually the first thing that you should see, ताकि पता लग जाए कि क्या, what are you dealing with, and then a sagittal PD as well. So just to show you the difference, This is PD fat sat. This is PD. Just looking at it, very difficult to say कि ये PD है, T1 है, T2 है. Yes, T2 we can see if we see fluid, but PD versus T1 very very difficult to say. Otherwise, just looking at the sequence, so you know, it's almost impossible. You can see the time TETR, and that might give you a hint, but otherwise nobody will ask you to identify a sequence. If they do, you can look at TRT to differentiate. Just the image will not help you. Gradient is pretty easy to identify, and stir, you will see fat suppression, right? So just given you these three, you can easily distinguish. Stir is something you do most importantly in MR arthrography, like you are seeing here. We'll talk about MR arthrography in a bit, but that's where you use stir really in all three planes post MR arthrography. So this is how the MRI protocol is. A special sequence is ABER view. I'm sure you know what is ABER. It's abduction external rotation. So you can see the patient position in ABER. Iska indication hai sometimes in labral tears to evaluate the anterior labrum, right? We will talk about a few variants like Perthes, Alpsa. उनको डिस्टिंग्विश करने में इसका सेंसिटिविटी इज अ लिटिल हायर सो some people recommend it, some institutes don't recommend it, so depending on how your institute does it, you may or may not do. It has very minor increase in sensitivity as compared to normal supine image, okay? And in partial supraspinatus tear, it can evaluate, it can help particularly in your articular surface tears, okay? So that is how it will help. So we will talk more about it. How will we know when to do ABER? These are the indications, right? So you start off with supine. This is an additional. You don't start off with this, है ना? तो ये extra sequence है which you can take if you're dealing with one of these things. These are the indications, right? तो ये तो करना ही है. This is extra, right? Moving on to just basic for very junior students. What are the structures which are going to be T1, T2 hypointense normally on any MSK MRI? Your bone, the labrum has to be T1, T2 hypointense. The tendons of all rotator cuff would be hypo on all sequences. The ligaments and calcification. So this is what we want to look out for. Any hyperintensity, it's going to be abnormal. Okay. So with this, the introduction is done. Now what I have to teach you is this. How do you go about reading a shoulder MRI? What is the normal anatomy? So essentially 1, 2, 3, 4, 5 compartments we have to see. Okay, one by one. आपके दिमाग में एक checklist खुलना चाहिए. Okay, coronal है. Coronal hai. Now, what are the things which I have to see out of these 5? Okay, so just like that, sequence wise, I'm going to teach you. First of all, overall, क्या evaluate करना है? Tendons. So there are 4 rotator cuff tendons, as I'm sure you know. 3 insert on the greater tuberosity, which are your sit tendons. So supraspinatus, infraspinatus, and teres minor. Teres minor not very very important to us, so you can skip that. So sit is what is on GT, and subscapularis, which is on lesser tuberosity. So this is what I need to see, and you know that this is the bicipital groove. जहाँ पे क्या जाता है? जहाँ पे long head of biceps is gonna course and it is gonna attach on the superior part of the glenoid labrum. I'm sure you remember from your anatomy, 2 heads होते हैं biceps के. The long head goes through bicipital groove and यहाँ पे आएगा superior part of glenoid labrum. The shorter head will go directly at the coracoid process and attach. Okay, so this is how you have the 2 tendons. Everybody understood? So this is your GT, supraspinatus, infraspinatus, teres minor, lesser tuberosity पे anteriorly. You can see ना कि lesser tuberosity आगे है. आगे subscapularis tendon होगा. Coracoid process, anterior most. That's the part we can feel, है ना? तो याद रखो coracoid anterior है. Subscapularis anterior है. Lesser tuberosity anterior है. All of these things will go together like I'll show you. Okay? So we have to evaluate these tendons. Ligaments, there are 3 glenohumeral ligaments, superior, middle, inferior. So look at this. This is a sagittal image. Okay, so ये anterior है, ये posterior है. फिर से orientation, you can see coracoid आगे है, acromion पीछे है, right? So here you have the superior glenohumeral ligament. This is middle, and inferior is this bifid sort of a ligament that you see, which forms the axillary pouch that we will see in coronal. Okay, so inferior, middle, superior glenohumeral ligament. ये 3 देखना है.